Theme today is equitable, accessible, and quality healthcare, responding through investments, partnerships, and technology. The evening will go as follows. First, we will have a keynote address on the screen by Mansukh Mandavia, Minister of Health and Family Welfare, India. Once that is done, there will be this dinner discussion with Mr. V.K. Paul, Member Niti Aayog, Sachio Imoto, Senior Vice President, Japan International Cooperation Agency, Shamika Ravi, Member Economic Advisory Council to the Prime Minister of India, Ricardo Baptista Leite, Member of Parliament, Portuguese National Parliament at Portugal. I hope I got your pronunciation right. Rajat Khosla, Director at the United Nations University, International Institute of Global Health, with the moderator, Anjali Nayyar, Executive Vice President, Global Health Strategies. So welcome once again.
Namaste. I am delighted to be here with you all for this event to deliberate on the importance of equitable, accessible, and quality healthcare service. India has always prioritized universal health coverage through various national programs. However, to provide momentum to the agenda, Honorable Prime Minister Modi ji launched the path-breaking initiative of Ayushman Bharat with its 4 associated pillars. Under the Ayushman Bharat Health and Wellness Center, access to quality primary healthcare services is being strengthened through establishment of 150,000 health and wellness center to provide preventive, promotive, curative, rehabilitative, and palliative care. Second pillar of Prime Minister Jan Arogya Yojana provides health assurance to 500 million citizens for identified secondary and tertiary healthcare services free of cost in a cashless and paperless manner, making it the biggest government-funded health insurance scheme of the world. Through Ayushman Bharat Health Infrastructure Mission, an outlay of 641.8 billion has been sanctioned to strengthen surveillance, create a network of integrated labs, infectious disease hospitals, and research network to aid ongoing COVID-19 response and manage future health emergencies. Fourth pillar of Ayushman Bharat Digital Mission seamlessly interviews these initiatives to create continuity of care and is working towards establishment of a digital health ecosystem. While the catastrophic nature of COVID-19 has been evident globally, it also highlighted the need for investment in healthcare system. India firmly believes in technology as a great enabler in healthcare services delivery and strengthening the pandemic response. Aligned with our data-driven and digital-first approach, we deployed cutting-edge intervention, leveraging quick, contactless, and innovative technologies to increase penetration of specialty health services and bridge the digital divide. We ensured that all relevant data is consolidated in a common framework through COVID-19 portal with data from 730 plus districts. Further, we have tracked more than 918 million tests conducted in the country on a real-time basis through ICMR's RT-PCR portal. India also launched e-Sanjeevani platform, world's largest telemedicine network ensuring free of cost online health services to citizens, and so far more than 100 million teleconsultations have been conducted. Under the visionary leadership of Honorable Prime Minister, vaccine management platform CoWIN was developed in record time and has been the backbone of the nationwide vaccination campaign with more than 2.2 billion doses administered so far. We also exported over 290 million vaccine doses to the world under Vaccine Maitri initiative. The government took decisive steps which culminated in effective management of COVID-19, where India's cases per million population of 32,786 and deaths per million population of 389 are significantly lower than the global average of 87,236 and 872 respectively. While on one hand we work towards saving precious lives, we also put equal emphasis on minimizing the adverse economic impact of the pandemic. India's COVID-19 management efforts have been lauded globally, and I'm happy to share that I recently inaugurated a report published by Stanford US Asia Technology Management Center, which has estimated the economic impact of India's key response strategies. The reports highlighted that India was able to save more than 3.4 million lives by undertaking the vaccination campaign, which yielded a positive economic impact of $18.3 billion, with the schemes launched to support medium and small scale enterprises, an economic impact of $100.26 billion has been noted, which is around 4.90% of the GDP. Similarly, under the Pradhan Mantri Garib Kalyan Anna Yojana, we distributed free food grains to 800 million people, which resulted in a positive economic impact of 26.24 billion US dollar. PM Garib Kalyan Rozgar Abhiyan provided immediate employment and livelihood opportunities to 4 million migrant workers, which resulted in an economic impact of 4.81 billion US dollar. While the global economy was severely impacted, India managed to sustain the economic growth and is poised to growth at a rapid pace. India aims to be the voice of Global South under its G20 presidency and is bringing together multiple stakeholders with action-oriented and impactful measures. We are espousing enhanced collaboration and investment in research and development of medical countermeasures and focus on strengthening manufacturing capabilities. We believe in distributed manufacturing of vaccines, drugs, and therapeutics with an emphasis on accessibility and affordability to ensure equitable healthcare. India is proposing a global medical countermeasures platform with focus on diversified manufacturing through regional networks to increase accessibility globally. We are also furthering the agenda of digital health during our G20 presidency with a focus on launching the global initiative on digital health as an institutional frameworks. We are building consensus on digital public goods to address challenges in universalization of digital health. India has already provided CoWIN, eSanjeevani and Arogya Setu applications as a digital public good to interested countries around the world. This demonstrates our commitment to global health and our role in driving innovation and equitable access to critical health solutions. It has become glaringly obvious that this pandemic will not be the last the world faces. We have learned the preparedness cost only a fraction, exponential of its impact, but the returns on this investment are exponential. We need more coordinated and effective global efforts to drive greater alignment and actions on key health, economics, and finance policy levers through knowledge sharing, technology transfer, and collaborative manufacturing. India leading the G20 agenda has opened avenues to revive, rebuild, and strengthen global health partnerships under the tenets of One Earth, One Family, and One Future. We believe that it is essential to adopt a inclusive approach aligned with the principle of Vasudhaiva Kutumbakam to ensure that every individual has access to quality health care. Thank you.
There was some good data out there. And now, once our fifth rock star is seated, I will hand it over to Anjali Nair.
Thank you, everyone, for joining us, and I'm so delighted to see a full room. I'm sure our conversation here will match you course for course. I think we've heard the minister, and he's really set the stage for the conversation ahead. But just a couple of points that I would like our excellent panelists to keep in mind. One, we know the extreme turbulence that the world has gone through, and we know that social, economic, and human resilience, that the kind of turbulence we faced, and for us to be socially, economically resilient, we will need new systems and partnerships that will allow the benefits of technology and innovation to really flow to those who need the most. And I'm hoping my panelists will touch upon points that give us insights to a potential for a global and inclusive blueprint for a health model, and a model that will catalyze knowledge sharing and technology transfers from R&D hubs to people who need it the most. There was one last point I want to make before I invite our first speaker, is I read a very, very powerful differentiation between equality and equity. Equality is giving all people same resources and opportunities. And equity means giving individuals or groups the essential resources and opportunities they require to be able to achieve outcomes as others. And I'm hoping as we start talking about the global health blueprint, we keep in mind how important equity is. So with that, I'm going to invite our first speaker, Dr. Vinod Paul, who I've known for several years from the time he was at that premier All India Institute of Medical Sciences and now at the Niti Aayog, where he leads health, nutrition, and human source development verticals. Dr. Paul is part of Union Government's core team for COVID-19 pandemic, and we look forward to your thoughts. May we request you to just give the opening remarks, and then we'll start with the rest of the panelists.
Good evening, my distinguished co-panelists, esteemed colleagues. The stage has already been set by the Honorable Minister of Health and Family Welfare in his opening remarks. I'll build on that, expand on that, and try to respond to the expectations set by our esteemed moderator. The world is still recovering from the pandemic. We've all gone through very difficult times, but even last month, 4.8 million confirmed cases of COVID occurred on this planet, with as many as 39,000 deaths. It's still around. The virus is still around, of course. We are better prepared, we are more protected because of the vaccination program the world over. The world has seen 758 million confirmed cases, has seen 6.9 million deaths, just to say that it was an unnerving shock that we all faced. We learned our lessons. We responded to the best of our ability in countries, in districts, in villages, and in cities. Economic loss, I'm told, is to the tune of at least $8 trillion. $8 trillion. The loss due to schools getting closed in terms of the impact on students during their lifetime perhaps adds up to something like $17 trillion over a lifetime of those who missed their schools and colleges. We also realized and recognized and learned our two very important lessons to set the stage. Investments in science and technology and epidemiology and health sciences and biomedical sciences pay us back. So very, very important, extremely important. That saved us in many ways, as we know. Secondly, strong health systems tend to respond better. Resilient health systems tend to respond better. Primary healthcare functionaries and primary healthcare systems ultimately deliver those tools that save lives and improve health. However, we experience less than optimum global solidarity. Another realization, not a lesson, but an honest realization. We experience less than optimum global solidarities. And we also experienced vast inequalities in access to countermeasures across nations and communities. We also learned to face a unique new form of pandemic and outbreaks, I should say, of infodemic. We'll remember that this will come in future, such challenges, and we must learn to handle it much better. Government of India's response to the pandemic could be characterized by 4 elements. We responded by whole of government action. All ministries, departments, sectors got together and worked. We responded by whole of nation approach. The Honorable Prime Minister reaching out to every state chief minister, working together, bringing consensus. And of course, whole of society response, because the Honorable Prime Minister visualized this challenge to be faced as a Jan Andolan, a people's movement. And that ensured that we were broadly, very broadly, as a nation, as a society, on the same page. We had vaccine hesitancy, for instance. We faced vaccine eagerness at times, but we handled it well. We handled it much quicker than many, many nations. And the 4th element has been the key driver, namely science and technology. And here, let me just elaborate in order to to visualize how India can partner with other nations in that sphere in particular, to which my minister had just indicated and set the stage. He mentioned that we were able to scale up from one lab, RT-PCR lab, to 3,300 labs. We approved 224 diagnostic tests, 80% of which were indigenous. In less than 3 months, there were 98 indigenous diagnostic tests by our Indian startups and companies and labs, which could be used for people. From scratch, this happened. And there is a lesson out there, and there is an offering from the country. We created a network of 59 sequencing laboratories and sequenced for genomic characterization more than 300,000 specimens. We created a system of surveillance which also included wastewater surveillance in 40 cities at least. We were manufacturing 0 PPE when we started our journey, ma'am. Then we were churning out 1 million per day. The vaccine story is well known in terms of the numbers. But what I want to emphasize is that India, made in India, we have a bouquet of 8 vaccines. 8 vaccines made in India have been licensed. We also licensed 2 foreign-made vaccines, which eventually we did not need. And we learned to be self-reliant because there were hardly any vaccines available for this vast nation. If we hadn't made our vaccines, we actually had no vaccines beyond a few small numbers. We practically had all the platforms from adenovectoral, inactivated protein subunit, DNA, RNA, the thermostable RNA platform. We produced these vaccines at a price that the government received under $3 per dose. Compare this with $20 and $35 per dose of the more famous vaccines. We today have a capacity of at least 4 billion doses of COVID-19 vaccine, should we need it, God forbid. If we don't need it, hopefully. The point is, India could mount its science, technology, and industrial enterprise to that level. First, to serve its own purpose of a large nation, of a large population, and then to be able to make these offerings to the world. And you heard from my minister, 258 plus 292 vaccine doses. Latter from COVAX, the other one from bilateral, and grants was offered to the world. 150 nations received essential medicines even in the midst of our own needs. 150 nations. I also want to mention here, from those who are familiar with trials, when we made vaccines, DNA vaccine and the Bharat Biotech inactivated vaccine, in the midst of the pandemic, studies were conducted on more than 24,000 subjects each. It wasn't a shortcut. We could mount that level of clinical trials on the ground on scores of locations, and it was aided by the government through a 900 crore grant-based COVID Suraksha mission. My minister just now mentioned about CoVIN, which steered the implementation of the vaccine, 2.2 billion doses. But I also want, and of course, the eSanjeevani, the telemedicine system that he referred to. But I also want to emphasize that at least 10 states, if not more, had their own individual apps curated in a matter of days to support individuals in home isolation, providing them support, getting feedback, delivering drugs and food. At least 10 to 12 states did their own, and many others also had other initiatives as well. I also want to emphasize that we delivered our vaccines through the public health system to the tune of 97.5% of the 2.2 billion plus vaccines were delivered through the government public health system. 2.25 came through the private system, showing the resilience of our health system. The minister has already mentioned about the poverty alleviation and other measures that the government provided. We also heard today that based on the Lancet report, 3.4 million lives were saved over 1 year period of vaccine implementation. The health minister mentioned this in his speech. Our vaccines were efficacious in preventing lives to the tune of 98 to 99%. That brings me to the second part, the last part, Anjali. We would request the world to look upon us, a nation with great science, technology, industrial, and innovation strength. You heard it from Mr. Bill Gates yesterday, and today the Honorable Prime Minister of Italy also referred to the science and technology strength that we have. We have 84,000 recognized startups. We rank third in the world for startup ecosystem. And our startups, half of them are located in tier 2, tier 3 cities. Our FDI intake in the last 90 months is 532 billion, of the total since 1947, since independence, being 950. World has trust in us. And this FDI has come from 160 nations. We are the fastest growing economy. We were the fastest growing economy before pandemic, and we continue to be the fastest growing economy post-pandemic today. The Honorable Health Minister has stated the approach that we are taking for the health sector, the three pillars of the approach that's being taken. I would not repeat. But what we offer to the world is the following. We offer to the world technologies, quality, affordable countermeasures, vaccines, therapeutics, diagnostics, and other medical products. This emanates from our science and technology and R&D ecosystem and our massive manufacturing capacity in pharma and related sectors. 2, we offer digital solutions that are generic, context-specific, and integrative across One Health spectrum. Future visualization is through One Health sector. It's the focus of the G20 discussions as well, including AMR. 3, in particular, we offer telemedicine-related solutions across borders. We have an emerging strength, phenomenal strength in this for the public good. And 4th, we offer our expertise in program implementation on scale. All this happened not because we were at zero, and then suddenly we rose and responded. No, zeros can't be heroes. We were somewhere already running a great science and technology and industrial enterprise and health programs in the primary care setting in particular, and we rose. And above all, we offer solidarity, consensus, alignment, and trust to work together going forward in the spirit of one earth, one family, and one future. Thank you very much. Jai Hind.
Thank you so much, Dr. Paul. I'm actually going to move to our panel now. And Ms. Sachiko, I'm going to ask you the first question. Would it be, before you respond, would you introduce yourself and then we can take it from there. I think one of the things that we've noticed is there have been significant changes, you know, in the way we look at healthcare, in the way people perceive it now and the importance it's got. And a lot of it has been precipitated by the pandemic. We've also seen discussions and changes in the healthcare delivery. And also we've seen changes in the expectations of people, you know, what they need now, what they're looking forward to now. This is going to create opportunities and new imperatives. And for that, partnerships is key. Given your experience, what do you think are the key lessons, learnings for good partnerships? What was a positive example and what was a roadblock that you encountered? And also, if you could bring in one sentence on how do we encourage government and private sector partnerships? How do we do away with that, still that certain level of mistrust that we have? So I'm going to give you 4 to 5 minutes so that we can then open it up and people can ask questions from each of the panelists.
Thank you, Anjali, for your kind introduction. My name is Sachiko Imoto. I'm Senior Vice President of Japan International Cooperation Agency, which is an implementing agency of Japanese government for the development cooperation to the developing countries. And I am responsible for our operations in South and Central Asia and also in health sector. And I'm delighted to be here to discuss about how we can construct more robust health system and partnership in health sector. So, when the pandemic hit, it's revealed that we had not been prepared for such, devastating communicable diseases. And we saw a lot of, sad events and a lot of, huge devastation in our economy, in our society, and so on. But also, we saw several moves, positive moves, which accelerated, in many fronts, especially at constructing or strengthening a global health architecture, and also strengthening the health system in, country level. And I would like to point out maybe 3 elements which would be the key for the effective partnership. The first, of course, political momentum and political will is a key to work together in good partnership. With regard to the global architecture, health architecture, active discussions are going on in international arenas, such as UN, G20, G7, and so on. And Japan, also with India, are playing leading roles in such a dialogue and discussions, including financial contributions. For example, establishment of Coalition for Epidemic Preparedness Innovations, we call it CEPI, as a R&D architecture in the world, that Japanese government contributed $300 million to establish this CEPI. And the fund from CEPI goes to several Indian pharmaceutical companies which support R&D. So this kind of leadership is quite welcome. And also we have been successful in establishing pandemic fund at the World Bank, which also the discussion started in G7 and G20s, and we have seen how we can respond more effectively once pandemic hits the world. I understand that improving access to medical countermeasures also has been discussed in February in South Africa, and in this conference also India and Japan have been playing a very active role in that. So we need to keep this momentum to go further, to push forward our agenda. And this year gives us very good opportunities for us because India is chairing the G20, and also Japanese government would push forward health initiative at G7, its G7 presidency. And there are several meetings or conferences expected at the UN summit in September, and we should not lose this momentum to move forward for better health architecture. And this is very, very important. And also, secondly, I would like to point out that at this global level also, but also at the regional level and at the country level, we need to have a robust partnership, and such a regional health architecture and bilateral or multilateral partnerships in a country, in each country is very, very important. Because at the end of the day, the country has to deliver. And the response in pandemic or any other health in emergencies, the context plays a role. And we need to understand the context to make the swift response. And usually regional architecture or regional organization could play a very important role. And in order to have that, we need to maintain this partnership in peacetime. And when this emergency happens, everybody start considering about only themselves. But to be the real partners, we need to maintain this partnership so that we can move forward with the agreed rules and understanding. And when pandemic hits, actually Japan or JICA could support several countries which we have been working together with the core hospitals and research institutes for more than 40 years. They played critical roles in delivering the tests and diagnostics, and they also supported the neighboring countries because we had this network in peacetime. So this kind of networking and maintaining that, making the common or shared values and understanding, including the human network, it's very, very important. And okay, the partnerships.
I will very quickly.
Okay, the public
Very
and
quickly.
private government, public and private partnership. I see it's very, very important that we have a clear framework in which the private sector can thrive in innovation and R&D. And we need to have the common rules and regulations so that the outcome of such a R&D and innovations can be enjoyed by everybody in the society. So such a regulatory framework, or maybe I shouldn't say regulatory, but kind of a framework for as a common goods, it's very, very important, and that the private sector can thrive. And the government sectors, including the government and international organizations, have the role to play. Thank you.
Thank you so much. I think that's one of the things that India has focused on, is really encouraging the private sector, and that's been really important. And when you talk about platforms, I really, we work with the African Union and the ASEAN platform, and as I mentioned, the ASEAN platform was really impressive in the way the countries stood by each other and really took their framework of cooperation seriously. So with that, I do want to come to Dr. Shamika Ravi. Congratulations again for your recent appointment to the Prime Minister's Economic Advisory Council. Just a bit about yourself. And I think one of the things I do want to ask you as a leading economist, India's done fairly well in investments in healthcare. Of course, we could do much better comparing to similar economies. What can you say about financing healthcare? So we bring about equity and not just equality, and the importance of data in that financing. So,
thank you, Anjali. Well, first of all, congratulations to ORF. It's one of the very few institutions which can manage an absolutely gender equal panel. So kudos to you. I think it's one of the reasons it's very important to talk about the real costs of the pandemic. And Dr. Paul has already outlined that it's not over. But the real costs must be reiterated. Many countries in the global south have fallen further behind in their schedule to attaining the Sustainable Development Goals. So the costs of the pandemic are going to linger for many, many years still. In fact, Anjali, when you say that we should do better than countries which are similar to us, actually we have. And you know the reason we say this? Brazil, South Africa, both these countries are substantially richer than India. And they are further behind in their SDG targets, largely on account of the pandemic. So this is not to gloat, but it's also very important for people to understand that public memory is very short. And we should not forget what countries and what we in particular have had to endure in order to come out ahead of the curve as far as the pandemic is concerned. Now, how do you prevent the next one, right? That's the conversation, because we all know that the next pandemic is definitely going to happen. The point is, how do you prevent it? How do you minimize its impact? Or how do you delay it, let's say, right? The issue is with this general amnesia, and particularly amongst the multilateral system. And multilateral system is currently under tremendous strain on account of various different pressures. The G20 presidency for India, as a champion for the larger global cause, becomes an extremely important one. Countries are still enduring the impact of the pandemic. Now, tech solutions become one of those key things, and I think one of the biggest reasons why we were able to prevail to a certain extent, because technology and the use of technology through the markets in the OECD countries, we've seen how much can be accomplished through creative use of technology and innovation. But the Indian model is a little bit different. And in fact, when the artificial intelligence policy was written a few years back, people would still ask, well, what is the Indian model for? You know, it's very clearly, and the pandemic has shown, it's going to be the one which really pushes public infrastructure, the global commons. It's going to be technology for the greater good, and markets and private firms are definitely a very large player. But the government has clearly shown that when the intent is right and the strategy and the technology exists, how much more can be accomplished by just leveraging it on a real time. Now imagine, for a country like India with $2,200 per capita per year, to avoid hunger deaths. Repeatedly, we are seeing studies after studies which are saying the pandemic has absolutely, it's not made any impact in the improvements in nutritional outcomes over years. You know, these are extremely gratifying to know, because if there was a country where you expected a devastating humanitarian crisis on account of a pandemic like this, it was here. And state after state, and the central government, and of course, I mean, maximum vaccine distribution happened. The production was from a private, it was from the industry, the Serum Institute, on the back of which we were able to leverage the manufacturing capability that Dr. Paul outlined. So all PPP, but leveraged in a way where I think equity was attained. Of course, more work needs to be done, and I come to your question now. How much more? You know, you can never have enough public spending in healthcare. And this I say as an economist, as an Indian economist who's been studying healthcare, we still have an out-of-pocket health burden which is around 45, 46%, which is still high. But we have to recognize in India, you have two extremely contradictory situations emerging, where if you look at access to quality primary healthcare at the local level, we are still aspirational. Therefore, the wellness center and the push towards making improvements on the ground. But at the same time, we also have one of the fastest growing sectors in the economy is medical tourism. We have some of the best super specialty hospitals. So we have two ends of the spectrum. And both these are in equal measures important as far as public policy is concerned, Anjali. I think eventually we have also realized that healthcare also needs to be seen as a sector, a strategic sector for economic growth. And the reason we say this is because the global economy and the affluent part of the global economy is aging very fast. And with aging, your medical costs are only going to escalate further, which means every economy will look for ways to manage these costs, whether it is going to be in the form of trained manpower, nurses, doctors, medics. It is going to be in the form of devices. If it is going to be in the form of artificial intelligence, and how do you deploy it for these different kinds of problems related to. The solutions can and have already started to be formed here. But again, the push that we need is, financing is one part of it. We also need to think of the healthcare sector as a strategic sector of economic growth. The way we have nurtured the IT sector, healthcare is going to do that for us in the next 100 years, because the global demand is only going to increase further.
Yeah. And yes, medical tourism in India is really growing, and that's one way of looking at it. Dr. Ricardo, I come to you next. You're a member of parliament, a medical doctor, and The Economist had listed you as an HCV change maker. Someone who'd worked on HCV and looking at infectious diseases with Global Fund. I think there was a very important point about political will. And how do you work to generate political will? If you could talk a little bit about Unite and a little bit about the shift and how you started working on health, and then say, how do you think political will can be generated across G20 countries? Because we have scaled back on SDGs. We're not going to make them on time. Countries are in a very challenging situation, and the G20 countries have to show the way.
So Unite, to start off with your question, is a network of policymakers, of current and former members of parliaments, congresses, and senates in 95 countries that work in partnership with WHO, and through which we try to support policymakers in a peer-to-peer manner in getting scientific recommendations into concrete policies, laws, and awareness campaigns. So it's bridging that gap, basically, because we know that that is probably one of the biggest challenges when it comes to evidence-based, science-based policymaking that we all call, that we all call for, but many times we end up not being able to achieve. But if I may, I want to address also the issues we were talking about here, because I think it's extremely important. The truth is, throughout the pandemic, we saw important shortages of goods, of essential goods, and this opened the eyes of many people during the pandemic. It led to a lot of transformative changes and a discussion on the need to shift from the one-stop shop model of globalization towards the distributed regional approach, which clearly is the way to go. But when we look at just a couple months ago, the World Economic Forum Global Risks Report, which is composed of opinions of world leaders, business sector, governmental sector, think tanks, and so forth, health emergencies are at the bottom of the list. We just came out of a pandemic, and it's at the bottom. And so there's always something more important, and I fear that we may have lost that window of opportunity. But that's where the G20 can play a very active role. And that's why I accepted the invitation to come all the way to New Delhi, because I believe that India can lead the way as the biggest democracy in the world, to push for health, to go beyond this reactive model of working only in emergency mode and building, as you were saying, not on pandemic preparedness and response, but on pandemic prevention. We have the technology, we have the knowledge, we know what to do. And right now, WHO is negotiating in an intergovernmental negotiating body, the pandemic treaty or the pandemic accord, depending on which geography you are, you have to use different language. And this accord will be critical to establish the ground rules of what every country needs to do to ensure that we can prevent the next pandemic. And we invested tremendously in genetic sequencing and so forth. We can use that clearly in our favor. But it's not just also the issue of access to technologies and access to goods. It's also investing in your health system, the health model you want to implement. I'll give you a very concrete example. In Portugal, my country, we are top of the list. We have been throughout the pandemic when it comes to vaccine acceptancy. Over 90% of the people accept being vaccinated. When you look to comparing countries, particularly in Europe, it's down at 50, 60%. Many people ask why. All of the countries that we compare directly to had access to vaccines. It was the fact that we invested for 40 years in public health policies and literacy and a strategy focusing on behavioral science that led to, when the emergency hit, people trusted the government, people trusted science. And this is a critical element. We cannot expect to be efficient when an emergency hits to achieve the outcomes we want. I would say that for us to go beyond emergencies, we have to do one thing, which is know exactly where we want to go, have a vision of a value-based healthcare. Most of our health systems are based on an industrialized model. Most ministers of health around the world, they'll tell you about the thousands or millions of consultations they've done and so forth. But at the end of the day, what do all those surgeries and consultations lead to? Are people better or worse? Are they healthier or not healthier? And in most, especially in the richer countries of the world, people were spending more and more money on a yearly basis, and people are getting more and more sick. The burden of disease is rising. This is a route to disaster. And so we need to change and focus on a new management model and a new financing model focused on health outcomes. And to do this, you need leadership on the ground. On the global health front, you need a second thing, which is a new financing model. And we have very good examples like the Global Fund, where, as you know, there is governmental money, but that has to be matched by the private sector, or sometimes multilateral money that is given by governments, particularly from richer countries. But even in low and middle income countries, there's a matching by governments in those countries, so domestic budgets contribute, and also the private sector. And so we move from a model in which we have this kind of charity, global north, global south, to where it's a shared common goal, and which we go towards a model in which actually we can focus on outcomes, and there is great ownership from countries, particularly in low and middle income countries. And through this, we can foster innovation. So to end, I just want to say then, based on our experience at Unite, you were asking me, how do you convince then policymakers to move in all of these different challenging directions? We've come up with the ABCDE model, and it's quite simple. And so A is awareness. If the constituents do not know what you're talking about, politicians will not follow. So make sure that the constituents are in line with what you're asking for. B is budget. When you present an idea to a member of government, make sure that you show where the money is coming from. Have a key in hand solution so your member of government knows that where that money can be found, and be very concrete on that. C is cost opportunity. We need to discuss, and we do not do it enough, the cost of inaction. It's not just pushing for new things. It's actually when a government decides not to do anything, that is a political decision, and that has a cost in people's lives. The D is data. Data will, as we've heard throughout the day, data is the electricity of 21st century. We need to provide the data, not of just where we are today, but what we will achieve with the implementation that we are proposing. Because this way, a minister today can present results in the future. And that leads to E, and this is extremely important for politicians, which is elections. Politicians in democracies need to win elections. And so when we present a solution, we have to think that that politician has a very short life cycle. Particularly ministers of health tend to survive less than others. And so we have to present not just long-term solutions, but what are we going to gain on a yearly basis? What can that minister present today? And by doing this, working together, transforming the way scientists speak to the policymakers, the way health advocates, really building up from the bottom, having active citizenship, I truly believe we can change the global health environment for the better.
Thank you so much. Rajat, you're the director of United Nations University International Institute on Global Health. Your research currently includes racism and global health, social justice, accountability, gender and digital health infrastructure, all of them absolutely, absolutely key. So, I mean, while you may be the last speaker, but definitely most important. We're talking about wonderful words here: social justice, equal rights and opportunities, right to affordable and quality health care. Everyone agrees that's there. Everyone agrees the world should do better. My question to you is, has the world done better? Taking from what Dr. Ricardo said, has the world done better? If not, what can they do better? Have we really missed the bus? Or can we still do better in preparing ourselves and making more resilient communities, resilient infrastructure, ensuring that everyone gets the goods and services they need?
Thanks, Anjali, and no pressure really to be the last speaker before the dinner is being served. But it very much building upon the remarks of the previous speakers, but particularly of your, Ricardo, but also Dr. Ravi, Dr. Paul as well. I think what is worth emphasizing is, for a moment, what difference does a justice framework bring to what we have been talking about? And what is important is that when you look at what COVID did, it basically laid bare the stark inequalities which already were there in many systems, in many settings. What COVID did was expose them to the world in terms of what they were, and a response, unfortunately, exacerbated them in manners that one did not think it was imaginable. People have been talking about a justice, fairness, equity approach for very long. There are people in the room here who have written books and papers about these topics. So I would not try to lament it beyond a point in saying is that what the justice approach makes us do is to actually question what are some of those underlying injustices that deny people equal opportunities to access to healthcare services, goods and facilities, differentiating between the achievement and the capability for individuals to be able to do so. Now, if I look at it from that perspective and answer your question, the unfortunate reality is a big no. I think we have missed the bus. Because unfortunately, what has happened is that we are in the rush to fix things right now. We are in the rush to fix everything that we think happened wrong with COVID-19 response, without realizing that there is a larger question on the table in terms of what got us into that situation in the first place. What were the aspects that made the COVID-19 response such a shamble in the world order? And if you come from that perspective, things start getting lined up very clearly. One of the first things that comes up, at least in my mind, and in our work that is being shown, is that resilience is probably not even the right framework to think about when you look at the vulnerabilities that face many systems around the world. The low-income countries specifically, there are no systems to be resilient with. There are no systems to absorb shock in most cases. So if we are going to build resilience as a matter of practice, we have to start much before the crisis actually happens. We have to invest in, as Dr. Ravi was rightly saying, in terms of primary healthcare, in terms of building systems, building preparedness. Everybody wants to be free from infectious diseases right now. But the irony is, when you look at the global conversations going on, nobody wants to invest in it. Nobody wants to invest in the CDCs. Nobody is wanting to invest in the public health systems. And if you change the lens a little bit, if you do build the lens from a health equity and justice perspective, first thing first, you start thinking about health as a global common right. And health systems become pooled resources for all of us to share and invest in. But if you do look at the investments, the irony is also that investments have essentially stagnated for the last 20 or so years in healthcare. You're looking at about $25 billion, roughly speaking, according to the 2019 estimates. What has happened, if you look at what the money is being invested in, is essentially in terms of procurement of medicines and vaccines for a certain amount of diseases, for a certain amount of beneficiaries. There is hardly any money gone into investments into infrastructure, health workforce, and so on. And so you're looking at there is a 70% shortfall in terms of investments that are needed in low-income countries. If you look at the data from sub-Saharan Africa, you have about half of primary healthcare facilities do not have running water and safe sanitation. A third don't have electricity. So what are we talking about? So if you do look at, therefore, the conversations that are happening around the pandemic accord and the new architecture that we are espousing, they fall way short of what a justice approach would be. Dr. Paul very rightly talked about what the ingredients are and what Honorable Minister of Health talked about previously in terms of what needs to be done. What needs to be done is investment in infrastructure in terms of breaking the dependence in global north when it comes to procurement, supply, and management systems. Our dependency in terms of supply lines is still very much, there is still very little investments going in setting up the kind of developmental facilities for medicines and vaccines in the global south. But we also need, and I'll end with that, 3 very quick points. The first is we need to shift the balance of power. Global health actors need to do better in terms of addressing the power differentials that exist. Aid cannot be seen, and global health cannot be seen as a humanitarian rescue mission of the global north. That has to stop. Global south is no longer interested in the patronage and charity models anymore. Second, we need to address the disbalance in terms of the corporate interest to maximize profit and the state interest to ensure rights of its population. Why is it that even in the middle of a pandemic, that issues of fairness in terms of procurement, in terms of supplies with the pharmaceutical companies were falling short? And finally, we need to redouble the efforts to strengthen the World Health Organization. It has to be invested in, but it has to be also reformed to deliver in the kind of global cooperation we need, not only to respond to the next pandemic whenever it might be there, but to the existential challenges that confront us today. Thank you.
Thank you so much. I mean, that's a very somber, thoughtful note. Yes, so we have questions here. Please introduce yourself.
Thank you. My name is Yun Fan. I'm an MP from Taiwan. Regarding the question where to find the political will or incentive for the healthcare reform, I want to share Taiwan's experiences. During Taiwan's democratic transition, actually, many researchers think that actually it's the cooperation between the healthcare activists and elected politicians that make the healthcare reform in Taiwan. So actually, we have the so-called national health insurance for all. So it's, relative speaking, it's quite inexpensive. You just need to pay a little. And my question is that regarding the gender issue, I'd like you to echo that. But you know, we found that actually compared to men, women are less, less likely to use the medical insurances due to maybe they live longer or they are alone. So you really need to have the social network or support to use the medical insurances accessible. So I'm wondering whether you have this kind of gender gap finding, especially during the pandemic. Thank you.
No, so this is a global problem, I think, and it's perfectly echoed in India as well. In fact, even during the pandemic, we had done district by district analysis of the gender gap in the vaccines itself. And knowing very well that this is an infectious disease, if the women in the household are not vaccinated, the household is vulnerable. And yet we did see that women did lag in terms of the vaccination. But I think the question on usage of insurance is very interesting. In fact, we have evidence from the southern part of India where we see that the households are paying. So these are not publicly financed. And this is where I think it's important to understand that it goes beyond just finance. The households are paying a premium. The whole family is covered. But it's overwhelmingly the men who are filing claims when they fall sick. So clearly, this is not a population where the women are particularly healthy, right? These are microfinance clients. It's just that women's health, in fact, for All India Institute of Medical Sciences, Dr.
Yes.
Paul, there is a 50% shortage. So 50% of female patients are missing. Now, All India Institute of Medical Sciences, which is our apex public health institution, it doesn't make the cost difference is nothing, right? There's no cost difference. These are societal norms. I think health seeking is a measure of empowerment. And women don't make their health-seeking decisions. It's usually made by the elders, the husbands, and so on and so forth. So finance is just a financial instrument. No? Insurance is a financial instrument. It's as effective as the care that it can buy.
No, I was just going to add, because this comment is extremely important. When, in most settings, when we see precisely the phenomena that you described and that you have described, what we see is then typically when we do healthy life years adjustment ratios in the elderly population, typically women present much worse health, which demonstrates that they put their health second typically to family and other obligations throughout their lifetime, but that comes with a tremendous cost in the future. And as populations are getting older, this will become even more exacerbated. And so it's just one more element of for us to acknowledge and address when it comes to the elderly populations. And when we talk about universal health coverage, it's not just ensuring access, it's actually making sure that we are measuring the health outcomes within the populations. Because if we were to do that throughout the whole lifespan, we would identify those problems way early on, and not just when people reach the health systems, typically with their diseases already in too much of a progressive state.
Thank you. Anyone wants to add before I go to the next question? Over to you.
This is for Ricardo and Shamika. You mentioned that when you make budgets, you have to speak about the budgets, you have to get the money, you have to convince the people about that this is the money for such and such problem. Shamika, I don't think such a political economy exists in India. If there's a problem, they want the government to solve it. It doesn't matter where you get the money from. We just want those freebies we just want health, we don't want to pay taxes and so on. So I feel there is a dichotomy between the way Portugal or the West examines its public finances and the way it happens in India. Just a short comment in case you want to talk about it.
Well, Gautam, I'll pick issue with that, and I'll tell you why. We have a very high out-of-pocket health burden on households, right? I mean, it's late 40s. Of course, we've done pretty well in the last 8 years because it's come down from 67 to 48, which is itself phenomenal. But it needs to fall further. 50 paisa per rupee is a lot of weightage, on private, on households, out of pocket. Now, the other part of the puzzle is that 75% of our OPD, meaning healthcare, consultation, is private. But that is really, it's symptomatic of quality of the public health institutions. It's never a choice. And we know in economics, it's very well understood that markets break down in healthcare. There is a reason you don't have a robust revenue model for primary healthcare, because the margins are so thin, the margins aren't there, the fixed costs are so high, that this is fundamentally a public good. The government cannot abdicate that responsibility. The government must do it. In fact, the data is overwhelming that in states where the district hospitals are good quality, people across the income brackets, meaning across quintile group, the poorest to the richest, would much rather go to a district hospital than a private clinic. And that's because the incentives are perfectly aligned. No doctor is going to overdiagnose, overuse facilities, put an extra stent because they make money. They don't make any money out of it. So incentives are aligned as far as public health is concerned. Private healthcare, there is a problem. That's why we say markets are broken. We have 50% C-section in private facilities versus 12% in public facilities. So the data is very clear that government health facilities must be strengthened regardless of the fact that our private healthcare is growing. It needs to grow further. We need to have a regulator. Quality is an issue. But there is no getting away from strengthening public health systems.
Yeah. Sachiko, do you want to respond, both you and Rajat, if you would like to respond?
Yes, thank you very much. Yes, the public health care, especially at the primary level, is a key for any health system, because that's the place you get prevention, and that's the place that will deliver at the last 1 mile. So investing in primary health care and establishing the working mechanism is very, very important. And in order to do that, we need to invest in people, human resource. And we need to invest over years. I mean, we cannot have the very trained human resources overnight. So we tend to forget the importance of retaining human resources, train, and not only once, but for the whole career path. And that type of policies and systems needs to be strengthened. And that's where a lot of partnerships can support. For example, JICA invests a lot in constructing or strengthening health system with technical support for capacity development and providing finance. But at the end of the day, the government itself has to finance, because our finance is just for the certain period of time. But this health care system needs to sustain. So, we really have to support how the government can, raise revenues and they distribute, allocate it to health sector. And that we need to have, continuous dialogues between, finance people, health people, and public.
Thank you.
Very much building up on that and also what you just said, Dr. Ravi, because I think it's proven evidence that primary healthcare investment is one of the most cost-effective models to invest upon if we are going to start building upon the resilience of systems to respond to all sorts of things. And if we do have a functioning primary healthcare system, the ability of the system to respond and absorb the shocks, both internal and external, is phenomenally more when you do not have that thing. In terms of the, and building on the point, so where does the money come from? And the primary healthcare strengthening model is an expansive one. It is also longitudinal. You have to infrastructure, health workforce, and other necessary aspects. And the work that has been done in terms of part of the initiative on global public investment is very telling. Exactly what you were saying is building the base in terms of the power of the co, that we start in terms of co-creation, co-building, co-payments, and co-benefits resulting from that. The challenge, however, is that we have an imbalance right now, which is slanted completely towards a private system in many countries, ironically, mostly in low and middle income countries. And the inability for us to rebalance between from the private to a public is what will require new streams of revenue, whether they come from progressive taxation or from other healthcare aspects that have been suggested in some countries, such as sugar, alcohol tax, and other things, provides opening up of revenue streams which can help generate and kickstart PHC models for the more longer term.
The alternate financing system. So
Hi, my name is Amit Paranspe. This is a question for Shamika, Dr. Paul, and indeed the entire panel. So we talk about how our investment in healthcare in India is lower than the global average, but we typically talk about the center. Now, states are supposed to do some of it, cities are supposed to do some of it. I would like to understand what is the global average or standard in terms of how these investments, clearly we are below average, but what should be the responsibility of cities and the states in this as well, and how other countries are doing it in terms of delegating it to the lower levels of government?
So there are a few champion models, Amit. Like Thailand has shown us that effectively by investing more in the public health infrastructure, costs can be brought down. Meaning because the private part, we know that markets break down, cost escalation. In fact, the simplest way to explain this is, the US spends 18% of its GDP on healthcare, the richest country in the world. And the health outcomes that it has, which is probably the poorest in the OECD, its outcomes are similar to Singapore. And Singapore spends 4%. They have very different financing models, right? One is an insurance-based, and to the economists in the room, this will be, but to the rest of you, my apologies, this is jargon. But there is adverse selection moral hazard. If I'm insured, I don't care if you write 20 extra tests. There is no incentive in the system, either from the patient or the doctor, to stop the overutilization or cut the costs, right? But Singapore's model is more like they have a certain pot which goes into social welfare, so housing and healthcare, etc. You don't draw down on something like that, because you want to maintain that pot because it's good for the household. So the incentives, we have to understand that financing is very key to the sustainability of healthcare. Now, the other issue is also how much of public healthcare can we afford, right? And this is where I think the states, when you mentioned, become very important in India. Our high mortality states, where neonatal mortality is very high, maternal mortality, they're highly correlated. But the reason I pick neonatal mortality, because it's a combination of, babies dying within 28 days of birth means the institutional support is so poor, right? And institutional support, places like MP, almost 80% of deliveries are happening in government hospitals because private chains almost don't exist, right? It's very contrary to UP or Rajasthan, where private chains do exist. But quality remains a huge problem. Now, these are also resource-poor states. So the dependence on National Health Mission and largest from the center are likely to continue, even in the long run. But again, it's very closely linked with the agrarian, the procurement policy. A state which produces the maximum amount of pulses does not procure pulses, so we are still feeding mothers rice and wheat, right? We want millet. So I think the effectiveness of the government policy, as far as health and nutrition, means we really have to overhaul the financing side of things. While at the same time, I think people go to private care because they really don't have alternatives. Any country. I think that is just the nature of economics. So regulating the private space, I think we will have to start talking more seriously about it to maintain the quality.
Dr. Ricardo.
Well, thank you. And following up on Dr. Ravi's response, I agree that that is the approach. And when we look around the world in terms of the different levels of government and different models of government that are applied to healthcare, we have seen that in some settings with a more local approach it does work better, in others not so much. In many Scandinavian countries, we see that the fact that they decentralized so much, it led that the councils or the states or the regions that are poorest just continue getting poorer, and the richest are getting richer in terms of their also in terms of their outcomes, not just in terms of their wealth. So having a mixed model, a hybrid model, in which you ensure corrective interventions, I think is critical. Having a very clear vision from the top, but then providing, yes, autonomy at the bottom to ensure that you're getting the response and you're adapting the solution. There is no one-size-fits-all at the local level. And the only way to do this in a way that is efficient, I go back to the same thing, it's outcomes, it's measuring. If you do not measure, you are in a ship in high sea, in the dark, no GPS, no lighthouse, nothing. That is where we are today in most health systems. But I also want to address the money issue because it's important, and it was mentioned before also. More money, as Dr. Ravi mentioned, doesn't mean better health. The US is the one that spends most than anyone and has worse health than many others. And actually, if you look at the graph in terms of health expenditure per capita versus outcomes, Singapore is one of the most efficient, but then it's a plateau. All of the countries that spend more than Singapore do not present better health outcomes, some even less. But in the US, where you have this problem, you actually have a good example. Kaiser Permanente, which is a health management organization, has 10 million beneficiaries. And so they work like an insurance firm. And what was the conclusion that they came to? People, if they do not get sick, it's profitable. So they started to invest in doing everything in their power to measure results and to make sure that people are healthy. And this is the critical factor. The problem in most health systems today is that we're putting money into a bucket full of holes, and it is not reaching the outcomes that it could. And we're going to see the needs grow, not just because of the elderly population, but also the cost of technologies, the rise of precision medicine, more specialized healthcare workers in a competitive global environment. It's going to get harder and harder. I just want to share one example, if I can, 30 seconds.
Literally, I'm going to ask for just 30-second comments from all and then closing
Then I'll say it for the
So you
end.
can say it then. I'm sorry, but I'm getting a real pushback there. So literally, a 30-second last comment, and I'll start with you, Rajat.
I think the 30-second comments will be, we stand at a crossroads in the conversations on global health today. The decisions that we make are going to impact not only in terms of our ability to respond to pandemic, epidemics, but also the future generations. We have talked about demographic transitions. We've talked about, issues in terms of heightened needs of social care and protection in different societies. One of the big challenges that the pandemic has exposed is the lack of trust in systems. Where we are right now are in a failure to take corrective measures and to rebuild that trust will mean that whatever future architectures that we are talking about or putting forward will have very limited viability.
Dr. Ricardo, your 30 seconds.
Yeah, so I'm going to end with an example from my country, because many countries like Japan will invest in cooperation, in investment in terms of health systems around the world, and India will invest certainly a lot in primary health care. So in Portugal, half of our primary health clinics are classical health clinics where everybody gets a salary no matter what they do. The other half, we have a model in which we measure results and we pay incentives. Just two examples, hypertensive patients and diabetic patients. When people are paid an incentive and we measure results, we double the number of patients that have controlled hypertension and controlled diabetes. So measuring outcomes and creating incentives, focusing on getting people healthier, has a result. So let's transform disease systems which we have today towards health systems that can drive well-being for all. Thank you.
Thank you. Again, 30 seconds.
So I'm going to completely switch gear and remind you, this is a G20 year. We have to come up with a few very specific things. And something that I'd like to put in your minds for consideration and perhaps development further. The pandemic is still not over in many parts. We need an early warning system. We need an early warning system. The poorer countries particularly are very vulnerable. That early warning system must be based on transparency of data. And the onus then is squarely on the WHO, and therefore the talk of reforms. When you talk of trust and confidence, it's not going to just come out of thin air. It must start at the top, and the early warning system is only going to happen if data sharing becomes more transparent, and the onus is put on member countries to share that kind of information. Thank you.
30 seconds.
Thank you. So we need to work hand in hand at the country level and at the global level, because we need to, we need to share data, we need to share information, we need to share knowledge to prevent the next, pandemic, because nobody can be safe when others are not safe. So we would like to, start building trust and using this momentum to support, each other in knowledge sharing and data sharing and also R&D, so that we can have the common, shared goal and values in health system. Thank you.
Lastly, Dr. Paul, I haven't given you any time after your opening remarks, so just a quick summing up. It's been very rich discussion. I don't think we can capture all, but a quick summing up. And as Shamika said, this is a G20 year.
This is a G20 year. Thank you very much. So here is my summary. What did I hear? Well, the message from Raisina Dialogues, the message from Raisina Hill, and the signal from the lighthouse, I like to summarize in 4 bullet points. 1, I think this fraternity out here, speakers in particular, are disturbed by the inequities in health, which got acutely exacerbated in the course of the pandemic. We are disturbed, we are worried. Inequity is bothering us. There is a call for justice, call for equity, and call to address the concerns of those who are particularly vulnerable. This is the first point that the panelists have brought out. Second, there is a strong call for enhanced investment for health sector, and by extension, the healthcare tools and solutions, including IT solutions, vaccines, medicines, delivery systems, and so on. There's a specific request coming out from the podium for thinking about how we can prevent the pandemic, and if we can't, can we have early signals and work together in that regard. But there's also a call from here that even in normal times, we should be addressing the health care of the people in a much, much better way for vast sectors of population. There is a refinement of the model, smart investment, right investment, primary healthcare was an example. And also, I'm adding this caveat to this, more health for the money that we spend, the efficiencies, the better governance system, and so on. The third bullet, strong call for partnership, working together, solidarity, strengthened WHO system so that it can perform much better next time around. So call for regional organizations, call for multilateral system, and that brings to the last point, using the G20 mechanism, the group and the influence it has, work together in that direction. That's one expectation. But there is a special expectation from India, I hear, and that expectation is play the right catalytic role, effective catalytic role to develop or to help develop a new global architecture in health, which meets the goals of justice and equity that we started with. And this should be built on trust. And I think India offers, from its track record, the trust. And I also refer to this. I heard that word again. So that's the expectation from India. That's the expectation from G20 this evening. These are the signals from the tempest, from the lighthouse in the tempest. Thank you, sir.